on to our next speaker, Dr. Siddharth Ghosh, who's a senior ophthalmologist from the Nightingale Hospital, Calcutta. And he has again a very interesting video, a great learning was going to come through it. On to you, Dr. Siddharth.
Thank you, ma'am. Thank you, Dr. Chitra, for giving this opportunity. Am I audible and is the video visible?
Yes.
Right.
Yes, please.
Okay. Good afternoon, everyone. And in the next few minutes, actually, we're going to discuss about true complicated cataract. And this is how we call the uveitic cataracts. This 46 years old male had recurrent episodes of anterior uveitis in both eyes. But now he is quiet for about more than 3 months. When he presented with gross dimness of vision in the right eye. And as you can see, there is posterior synechia. We make the incisions, and with a blunt spatula, we try to do synecholysis and under viscoelastics, of course. And once this synecholysis is done, I try to peel off the pupillary membranes. Unless we peel off the pupillary membranes, we cannot stretch the pupil. Once that is done, we go ahead and put some more viscoelastic and then mechanically stretch the pupil with 2 devices so that we can implant a pupil expansion device. In this case, I have just put it in and I have tucked the pupil underneath the flanges so that the shape is maintained and so that we have adequate visualization for a good capsulorhexis. And then under the viscoelastics, I start painting the white anterior capsule of the white cataract. And then again, once the stain is taken up, I use more viscoelastics to clear up. And gradually, I fashion a capsulorhexis as large as possible in this situation. And, it should be adequate. In all uveitic cases, post-uveitic cases, we need to make adequate size of capsulorhexis. And you can put in more viscoelastics whenever required and grasp and regrasp to make sure they don't go to the periphery. It's a white cataract, as you can see. And once that is done, a routine hydrodissection. And as you can see, it's more of a soft cataract, which will not crack as well. And it comes out as flaky material. And really, I have used very little energy because not much was required. It's a very soft cataract. Once that is done, we do more, irrigation aspiration to take out all the white material, the cortical material. And once all the cortical material is thoroughly cleaned, we need to make sure that we clean up all bits that is visible, that is possible, so that they don't react later. And once that is done, you can see that maybe there's a little D-shape of the rhexis, but it's adequately sized. And I put in a hydrophobic acrylic intraocular lens in the bag. And of course, we need to expand the pupil expansion device now. It's very simple to take it out. And once that is done, we need to thoroughly clean up all the viscoelastic that we have used, and also from behind the IOL. That is important. We cannot leave a little bit behind the IOL as well, so that it doesn't be the nidus for more cells to get accumulated. So the lessons learned in this case was that synecholysis and pupillary membrane removal is very important. And anterior capsular painting with trypan blue under viscoelastics is important for good visualization. And we need to use judiciously any of the pupil expansion device to achieve adequate size of capsulorhexis. And of course, the choice of IOL in these uveitic cases is very important. Thank you so much.
That was a superbly wonderful video, Dr. Siddharth Ghosh. Actually, you've told us everything which is there that to be done during the procedure you have explained. So I think we have to go on to a different mode of discussing the theory behind the uveitic cataract. So the question which I would want to ask the expert panel or even Dr. Siddharth, whoever, what I want to know is, what kind of pupillary dilating drops would you want to use in these eyes and why? Like,
ma'am, you're asking me?
yes, yes.
Okay. I generally try to, if it's a long-standing event, like very old, we know that there are a lot of Saniki.
Yeah.
I would like to use atropine even initially because they have already received that maybe earlier, but this time I wish to. But even then, these Saniki won't go away. So we need to be prepared that we will need to do sanicolysis intraoperatively, and that should be the first step. Now, some people would prefer to do it under, BSS. So that they can stay
post-operatively.
Oh, post-operatively, sorry, post-operatively, I use homatropine for a long time, at least 10 to 15 days, so that they don't get synegia later. There is no pupil addition to the IOL. And that's why you need to make a bigger rhexis as well.
Yeah. Also, we want the pupil to be mobile. So if the inflammation is extremely well controlled, there is even a logic in using a tropicamide drops and use it 3 times a day or something. And if you want an inflammation control, because you expect a smoldering infection to be occurring in the post-operative period, then maybe a homide would be the better way to go. Then as far as the management of the whether you want to give, when would you think of giving oral steroids? When would you want to give intravitreal steroids? When would you want to keep them only on topical steroid? I would want some thoughts of Dr. Mohan, Dr. Ramurthy in
this case, Chitra, I would like to congratulate Siddharth for the wonderful video.
Thank you, sir.
Yeah, but what I would have done differently in this case, I would have used intracameral tricot at the end of the case, and also subtenons Kenacort I would have given. And if the patient has got intermediate uveitis, a complicated cataract, then I invariably give intravitreal Osidex as well. So, but in this case, anterior uveitis only, the posterior segment is fine. Intracameral tricot and all other things, I think I will agree with you.
As far as the oral steroids are concerned, in the case of uveitis, like I would just going to give a short summary. I would want you all to add on your thoughts to it. See, this complicated cataract, when you see, it could be a case of just an anterior uveitis, wherein you need to keep the patient, wait for eye to be quiet for 3 months and start them on oral steroids or topical steroids a week or 2 before and keep them on continue the medication, would taper the oral steroids over a period of time, and not those very mild uveitis, as the most significant uveitis. It could also be that anterior uveitis is happening and there is no fundus view is there. Then again, you are not aware of what is the etiology behind this. Then again, you should be starting the patient well in advance with oral steroids. And then there are some surgeons who would also like to give subtenons, as Dr. Mohan had said. But there are situations where you can see the fundus and you know that there is a fundus pathology here, then it makes sense to give Osidex injection even a month back, treat the macular edema, and then go ahead and do a cataract surgery and follow it up. And if this patient is on immunosuppressants also, you need to start oral steroids if the patient can tolerate it, if the patient's immunosuppressants have been stopped by any chance, and keep them on oral steroids, start the immunosuppressants because they start kicking in after a month, and then gradually taper the oral steroids and then continue the patient on immunosuppressants. So essentially, when you just see a complicated cataract, you need to go into the history of the patient. And there are some patients who could even have a phacoanaphylactic kind of a reaction when you need to take the cataract out along with pumping in all the steroids, oral, topical, subtenon, and everything else. I want expert panel to please add on whatever they want to at this point of time. Anything else to add?
Congratulations, Siddharth. I mean, excellent surgery, very well managed. Just for the sake of only point I might have done differently is that, as you rightly said, it's not just the synecholysis, but the removal of the membrane is most important. And it also depends on the timing of your dye injection will depend on the type of viscoelastic that you're using. Most often, many of us are using HPMC. In that case, if I'm planning to use HPMC, what I do is to just inject an air bubble through the side port and then go through and release the synechia through the side port using an iris spatula, inject the dye, under the iris and then subsequently go ahead with the rest of the steps that you showed. Is simply because if you have HPMC there and then subsequently you use dye, then the dye doesn't take up too well. It becomes too granular. So the kind of painting that you showed is possible only more under cohesive viscoelastics. So specifically that needs to be used. Otherwise, surgically, I have nothing much to add. As Chitra was pointing out, I think now, except for those complex cases of uveitis which have undergone a uveitis workup and we are managing it along with that expert, then immunosuppressives, oral corticosteroids, etc., may be necessary. But most often, I think nowadays with the availability of intravitreal long-acting dexamethasone, that injection often takes care of recalcitrant uveitis for a significant period of time. So adding on a PST, posterior subtenon's tricot, or a intravitreal Ozidrex most often takes care of inflammation. Of course, putting on a cycloplegic for a couple of weeks after the treatment, and maybe starting with 8 times drops and slowly tapering it down. A little more than what we would for a conventional cataract surgery. It's what's needed in these cases.
Dr. Rohit Omprakash, you have joined in. You want to add something?
I just joined in. I didn't see the case from the next. Yeah.
Okay. Dr. Kapil, would you want to add, or shall we go on to the next video?
Let's go on to the next case since my screen has also gone blank.
Okay.
So I'll be rejoining.
Okay.